Right. Well, good evening, everyone. My name is Chrissy Kelly, and I'm the founder of AbScent. Welcome for, I don't know how many we are. We're in, I think this is the fifth in our Tuesday evening Zoom series. This evening, if you don't know him already, we've got Simon Gane, who is an ENT and rhinology consultant at the Royal National Throat, Nose and Ear Hospital. Hi, Simon. And we also have with us Aidan Kirkwood, who is being the moderator tonight. He will be manning the chat bar. And if you have any questions that you would like to put to Simon or me, please put those into the Q&A bar. You'll find that at the bottom of the screen. And if you have any technical issues, you can just go to the chat bar and put in a little message. That will, Aidan will be keeping an eye on both of those channels to make sure that you get the most out of the evening. We were just chatting before we came on air. This is probably the third time maybe that we've spoken about polyps. Always a very interesting subject. As Simon pointed out on Twitter this evening, he loves talking about polyps, especially at dinner parties. So without further
ado, I said that's why I never get invited to dinner parties.
This you're here.
Yes.
That's all I do, yeah.
Yes. So I think what we're going to do is, I know polyps is a complex topic. I know chronic rhinosinusitis comes with and without polyps. But Simon, why don't you start by giving us a little bit of background about chronic rhinosinusitis, and then we can explore more about polyps and all the things that make living with polyps a nightmare. I know many of you in the Facebook group really struggle with this. So let's take a look at all of those areas. But for right now, Simon, take it away and give us your potted history of CRS and polyps.
How long do you have? So, the important thing to realize is that doctors don't like to make things easy, especially for non-doctors to understand. But there's usually a reason why we have these sort of complex terminologies that we use. And I think actually we're not helped by the fact that we don't have a nice single word name for the disease that we're going to be talking about, diseases that we're going to be talking about. So polyps is a good one, but polyps just mean a lump of flesh somewhere. They're supposed to look like sea anemones. That's where the term originally comes from, and it was coined by Hippocrates actually. So we've had them for thousands of years. We've known that they exist for thousands of years. But actually, the more that we've understood them now in the last certainly 10 years, the more we've realized that maybe a better way to think about polyps is as a final end state, as a symptom rather than a disease. So inflammation in the nose, if it goes on for a long period of time, causes nasal polyposis. And it doesn't matter how that inflammation starts, and there are different ways of getting inflammation in the nose. But as long as you have it for a long time, the sort of ultimate end point of all those things is the same thing. It's polyps. And so that's obviously way too general for doctors. So we talk about a picture of chronic inflammation. So chronic means long-standing inflammation. Rhino means nose, sinus means sinuses, obviously. Itis means inflammation. So long-standing inflammation of the nose and sinuses. And the simple sort of dividing point used to be that we recognize that there are two broad syndromes. You had long-standing inflammation, and for a lot of people that made them make polyps. So the swelling in the nose got really bad, the fluid in the lining of the nose, the cells that were recruited by that inflammatory process caused the lining of the nose to swell and fall away from the side wall of the nose, and that formed these bags of fluid, which we call polyps.
So Simon, let me just stop you right there and ask you, why is it that some people can have inflammation and not develop polyps, but some people do? So what's the difference?
As long as you can, if you work that out, tell me, because we'll make lots of money.
Right.
We don't understand. So it looks like there actually, so inflammation is a broad term to talk about mobilization of certain cells from the blood into the tissue, and other sort of phenomena. But actually there are multiple different types of inflammation depending on the cell types that are involved. And so what we've come to realize is that people can get chronic inflammation in the nose, but it causes more scarring or pus formation, but doesn't really cause the swelling and the polyp formation that we call chronic rhinosinusitis without nasal polyposis.
Mm-hmm.
Or you can have a different type of inflammation entirely, what we call T2, just because that's one of the characteristic cells in there. And the cells are
T cells, in other words.
T cells, T helper cells, yeah.
Right.
But the specific types of T helper cells, so T helper 2 cells, there's Th2, or now we just call it T2 inflammation. And this cascade of inflammation was originally meant to help us fight parasites.
Oh.
But obviously we don't, you know, for some reason a mistake gets made in the nose. This inflammatory cascade gets activated. The nose starts to fight parasites, but there are no parasites there. It's a battle it can't win. So it's constantly sending out signals more and more. We're fighting. Lots of destruction of normal tissue, scarring and fibrosis. So the sort of you can imagine the difference between a skin scar and normal skin. Well, that can happen in the nose, and then you get these swelling and polyps and blocking of the nose.
And is that then the reason why some people who have this condition lose their sense of smell? Does the olfactory epithelium also become scarred, or does it just become blocked by the inflammation that results from all of this? Or let's say,
as you well know, yeah. So I used to think, oh, it's just, you know, polyps in the way, take them out, and this is, you know, being a surgeon, cut it out and it should get better. But actually what we know now is from biopsy studies that there's a direct inflammatory attack on the lining of the nose as well. So you can look and see that the nerve cells that should be hanging into the nasal mucosa, picking up the olfactant molecules, get attacked and die off from a direct chemical attack, not just the blockage. Always
or sometimes?
Degree of both. Mm-hmm. So there's probably always a slight attack on those cells, but if it's well controlled with nasal steroids, or, you know, it's a mild attack, then usually taking the polyps away makes the sense of smell come back.
Right.
So it's more obstructive than nerve.
Right. Okay. Tell me now about the relationship between polyps, and that we mentioned this before we went on air, and allergies, for instance. Mm-hmm. Is there a relationship, or are allergies another one of these unfortunate conditions that people can have with their nose, and then it all kind of gets mixed up in one, because sometimes people actually have a bit of both?
Yeah, that's exactly right. I mean, it's more complex than that, of course, because it's rarely ever simple in the human body. But and some of my medical colleagues don't get this. Allergic rhinitis, hay fever, nasal allergies. That's an entirely different inflammatory system, entirely different. Well, not entirely different mediators of inflammation, chemical signals of inflammation, a response to proteins in the environment which are misrecognized and cause histamine release, which is the one that makes you itchy and sneezy. And that's why antihistamines work for allergies. That's one kind of inflammation. But that's an entirely different disease to chronic rhinosinusitis. Now, there's a couple of overlaps. One, there are only so many things that can go wrong with the nose. So an allergic nose is blocked and sneezy and runny, but often has sort of eye symptoms and other indications of allergy. And that can look very similar to somebody with, say, chronic rhinosinusitis with nasal polyposis, who will be blocked, not so irritable, actually, usually, so not itchy, not particularly sneezy, but runny, with a loss of sense of smell and facial pain or pressure. So there's a symptomatic overlap which confuses things, and then there's a causation overlap in that we think that allergy may have a role in triggering, even though it's a different disease, may trigger chronic rhinosinusitis and nasal polyposis through a number of mechanisms. It certainly disrupts the integrity of the lining of the nose, so it makes it more wholly, if you want to put it that way. So the bits of the outside get in more than you would like them to. They can then, because they're deeper into the sort of through the protective barriers of the body, they can stimulate stronger reactions than if they were just on the outside. There are direct effects of certain chemicals in those inflammatory pathways for allergy that can affect smell themselves without causing necessarily blockage. And of course, the blockage itself from having a blocked, runny, sneezy, itchy nose can affect the sense of smell. Right. So it's complicated, and part of my job as an ENT surgeon or rhinologist when I'm seeing somebody who's presenting with these things is to work it out, to tease out the different roles that things are playing.
So how do you do that? Let's say you have a patient in front
how do I do my job?
Who has all these kind of things, presents with all these problems. Where do you start to unravel the problem? I mean, because I know several people who seem to have a very, very, they're just burdened with everything. So where do you begin? Do you begin with blood tests? Do you scope their nose? What do you do?
First thing is just to listen to the patient, to take what we call a good history, because there are clues from the beginning. Is it seasonal? Does it always happen in the beginning of spring, for instance? That's going to point you to certain pollen allergies. Or is it worse in winter when the central heating comes on? Or is it worse all the year round? Are the symptoms more of itching and sneezing, or are they blocking and running? What does the sense of smell do? Is it always there, always gone? Is there associated facial pain or pressure? Are there other things going on? Chest, so asthma, eczema. Did you have a history of allergies in childhood? Do you get better with a nose spray? Do you get better with an antihistamine? So all taking a careful history, and it's a bit of a truism in medicine, but my father, who's an anaesthetist, or goes on about this at length. He always says that the history is the most important part of any medical interaction, and for this, it's definitely true. But that's not the only thing. We can look and see. Obviously, if you look into the nose, not that we're really allowed to do that much anymore at the moment, but if you look into the nose in somebody with allergy, if they're in the allergic season, is usually quite boggy, quite pale, not always, and quite wet. The polyp nose is quite characteristic. Obviously, you'll see polyps. And somebody who has chronic rhinosinusitis without nasal polyposis in the more what we call a purulent subtype will have obvious pus or infection around there. And then there's sort of other things that you can see.
Right.
And then you have to go on to do the test that you were talking about. So we, in our rhinology clinic, will do a full workup in terms of looking at how open the nose is, looking how the nose works, looking if there are any reactions on a skin prick test to common inhaled air allergens, and then characterize what we call the phenotype. So some blood tests to look and see what are the cells in the blood doing. Because as I said before, this T2 inflammation is not just in the nose, it's systemic. Most of these people who have polyps have asthma, and it's actually the whole body that's mounting this inflammatory response. And you can see that in the blood. Usually they have high counts of cells called eosinophils, which are kind of, they're repair cells, but it also have to do with allergy. You can look at the immunoglobulin E, which is the immunoglobulin associated with allergy. That gives you some idea. And then you can look at specific antibodies to certain allergens if you want to sort of narrow it down. Right. But for me, the thing that I like to see the most, and also we do some blood tests to exclude other very rare causes of similar conditions. But the thing I pay attention to the most is the eosinophil count.
Right, right.
We have a question here from John for you, Simon. And John says, I was fine with polyps. It was when I was prescribed steroid nasal spray, Avimis, to supposedly get rid of them that I lost my sense of smell. Could the spray have been the cause? Is it just a coincidence? And then second question from John is, and why are ENT doctors reluctant to remove polyps, either privately or on the NHS?
So the Avimis question first. Obviously, we can't be 100% sure. whether or not the Avamys was causative agent. For most people, it's beneficial. It's not the best treatment for chronic rhinosinusitis with nasal polyposis. Some people are lucky and it controls things, but and maybe I'm biased because I see people with very bad disease, but generally you need a higher dose of steroid into the nose. I wouldn't say for certain that it isn't causative, but it is unfortunately the natural progress of the disease to lose your sense of smell as well. So it's difficult to just rule that out. One way of finding out, of course, is to use a higher dose steroid, either in a drop form in the nose or an oral steroid, and seeing what response is. And the reason that doctors are reluctant, actually, I think this is probably a good thing. The reason is that they come back. This is not curative. It's not like a benign tumor, for instance, where if you get it all out, it's gone. Those cells are gone. And this is, as I said before, this is a body problem. This is a mistake the whole immune system is making. And if you make that mistake, take those cells out, the polyps will come back. And you know, I have patients who've had 20 operations to try and remove the polyps, get a bit tired of it after a while. Oh. So surgery has its place. Don't get me wrong. I operate on polyp patients, and it definitely can be very useful. And for some people, a small percentage, it can be almost curative. But it's really a combined medical and surgical approach now for the management is what we'd recommend.
A couple of things that I'd like to clarify that I've been thinking about as you've been talking. One, you mentioned that you can't do endoscopy now. And I just wanted to clarify that because of COVID-19, there is a risk with endoscopy. Simon, you might want to tell them the whole story, but just let them know why it is that here in the UK anyway, the latest directives are not recommending that procedure.
Well, yeah, it's again slightly more complicated than that, but yes. So the virus is presumed to replicate in the nose, and if you stick something into the nose and wave it around in the air, which is essentially what you're doing when you do nasal endoscopy, then you're spreading the virus. So when we do it in the old days, we were careful, wore gloves, and scoped everybody, but didn't really worry about viral spread. But now we are in full suits of armor with double gloves, theatre gown. It's like doing an operation. Theatre gowns, FFP3 mask, visor, hat, the whole 9 yards, just to put a scope into people's noses because of the concerns about spreading the virus. It's probably actually not what's called an aerosol generating procedure unless the person who's having it done is COVID positive and actively infected, shedding the virus, and sneezes or coughs. But we don't take a risk at the moment. So our ability to look in people's noses is very much limited at the moment through an abundance of caution, I think. And that may change, but at the moment, yeah, we try and it's only for the most important or the most difficult cases that we reserve this.
Right.
So if you had to do that before COVID-19, did you ever have cases like that from different infections, or very infectious ones, or?
Yes, so there were concerns about TB and HIV, but you know, they were never really aerosol spread. It had to be direct contact, so just simple sterilization would sort all of those things out. The problem with this virus is it's droplet spread and extremely infectious, and that's the difference. That's the change.
So we've got 3 more questions here coming in just now. Stephen asks, is it true that you have polyps on both sides of the nose and not just one? I thought I had a polyp, but I was told you don't get them on one side only, or is it very rare?
So yeah, more complicated than that. So we've been talking about chronic rhinosinusitis with nasal polyposis, this sort of mistake that the whole body makes, and therefore if it's the whole body, generally you get them on both sides. There are other types of polyps. There's one called the antrochoanal polyp, which just forms on one side, and it's basically the lining of the cheek sinus gets sealed off and gradually blows up like a water-filled balloon and goes back through the back of the nose, and that's unilateral. That's only on one side. And also people who've had polyp surgery can get a recurrence on just one side or the other, but generally you're right, it's both. Unilateral polyps need to be taken out. That's an indication for surgery, because you don't know what they are, and they could be a benign tumor, for instance.
Right.
Got another question here. I've had chronic sinusitis without polyps for 9 months. Does chronic sinusitis ever go away? I have no allergies, asthma, or major structural issues.
Again, so without giving specific medical advice to anybody, which we always have a disclaimer at the front of these, that I cannot comment on anybody's particular case or give advice. In general, the word chronic sinusitis makes me slightly concerned. Sinusitis is an umbrella term, and the problem is it gets contaminated with the popular view of facial pain. So very often in our culture, we conflate the two. We conflate facial pain with sinus disease. But actually, if you look at the vast majority of people with sinus disease, severe sinus disease, so again, we're talking chronic sinusitis, rhinosinusitis, with or without polyposis, or say something like a mucocele, so that's where the sinus gets sealed off and gradually expands, filling with mucus. The facial pain is a very small aspect of that. They very often, in fact, majority don't have facial pain. So facial pain is really not a good predictor of whether there's something going on in the sinuses. It's usually itself. It's a syndrome of facial pain. You can get facial migraine, for instance. You can get dental disease, all sorts of things. So facial pain is another entirely separate entity and needs to be investigated for itself. But if we're talking about chronic rhinosinusitis, it's a small amount are treatable. A minority get better with surgery. Probably the majority are manageable with topical steroids, sprays or drops. And probably the majority of my patients, however, it's very difficult to manage and is a challenge, which is why we have a specialist rhinology clinic with both a surgical rhinologist like me and a medical rhinologist who's trained in this kind of inflammation and asthma.
Maybe this is a good time to ask you about biologics.
It's always a good time to talk about biologics.
I mean, I know that it's the sort of silver bullet for some people. Why would it work for some people and not others?
Well, again, this is another very good question.
Yeah.
If you find out the answer, we'll make a lot of money. Let's start at the beginning. So biologics are called biologics because they're biologically manufactured drugs. They're not, most drugs up until now have been what are called small molecules. So they are built in a lab for whatever reason, discovered serendipitously, like penicillin, or made and synthesized in big chemical factories. But biologics are shorthand for what are called monoclonal antibodies. So antibodies are the way that the body, all animal bodies, recognize shapes. And why is that important? Because a molecular shape tells you a bit about the molecular function. So our immune systems have hundreds of thousands of tiny little three-dimensional locks that are going around sampling all of the keys that are floating around in our bloodstream and in the body. And these locks have little attachments on the end of them. And if they bind to something that they for instance, a viral protein or a signal of a bacterium, they can activate they can lock onto it, and then they can activate the immune system with the little tails and say, there's something you need to do about here. Get me a macrophage, a cell that's going to swallow this, or get me something that's going to kill this cell because I think it's got cancer. It's got all of this sort of scanning system looking at the molecular shapes around this. And so what we've done is taken that and said, okay, these locks are great. We can make them to fit almost anything that we need to control in the body. And we've started using them in all sorts of diseases. We can knock out a certain class of immune cells, B cells, with something called rituximab, which has revolutionized the management of the cancers of those cells. Or we can knock out, we know that there are certain proteins that are involved in the immunology of cancer. So they act as a brake on the way the immune system reacts to cancer cells. Cancer cells are very clever, then they can dodge this CTLA, but we can make an antibody that recognizes CTLA, put it into the bloodstream, it binds to the CTLA and switches it off. And so these are going to be a very powerful tool going forward to manage individual signals within the chemical cascade of information that triggers a lot of the biological processes that we're interested in. And so we know that in eosinophilic chronic rhinosinusitis with nasal polyposis, this T2 type inflammation, there's certain chemicals that are the signals of this kind of inflammation. So the signals, the inflammatory cells are in there and they're going, we need more of these signals, we need more of those. And they do that by releasing certain chemicals called interleukins, specifically interleukin 4, 5, and 13. There are others, and it's really not important what their names are, but those
are available.
Other than, yes, exactly. And they can, these interleukins call more cells in, they release more chemicals, they really potentiate this whole cascade. So the clever scientists thought, well, why don't we just see if we can find one of these locks that binds onto, say, interleukin 5 and inactivates it. There's too much interleukin 5, let's just switch it off. And so the monoclonal antibody revolution has come about with a clever ways of developing and manufacturing these things. So now we can give you a pure shot of anti-interleukin 5, an injection under the skin that just reduces your interleukin 5 and stops that signaling process dead or partially dead.
Fantastic. And who does this?
It is fantastic. Well, again, you need to pick the people. So if it is, and the vast majority are, this syndrome of people with asthma and chronic rhinosinusitis with nasal polyposis, which has got a high eosinophil count in the blood, so there's T2 inflammation, knock out their interleukin 5 or interleukin 4 and interleukin 13, and the polyps can just shrink. I mean, I've seen some amazing changes. It looks almost like they've been cut out. They just go away.
And is there any way that you can tell whether or not a patient is going to respond by looking at their blood work or anything like that? Or is it really a suck it and see kind of thing?
No, so we're working at the moment to find out. I mean, we know from asthma, so some of these drugs were originally developed in asthma because the same interleukins are involved in asthma. And when they were first developed, the drug companies were, oh, okay, now we've got this thing, it's going to switch off asthma. We're going to come in. And they did the first trials, and they took a whole load of asthmatic patients. And the definition of asthma is a reversible airways obstruction. So something you take an inhaler, a blue inhaler. If your airways obstruction gets better, then that's asthma. Put them all in, tried these drugs, and they didn't work. And they were like, but we know that. And it was only much later when a clever researcher in Oxford, Ian Pavord, worked out that they were not stratifying them in terms of the type of inflammation that they had. They went back and looked and said, okay, if we give it to eosinophilic asthma, it's allergic type asthma with high eosinophils in the blood, what happens? And they noticed that they're the ones who get better. And so this makes a lot of difference to some people. And these people have been on oral steroids, these horrible drugs that have all sorts of side effects. Your bones fall apart, your skin gets thin, you get fat redistribution, what we call the orange on sticks, where very thin arms and legs and a sort of what's called a centripetal obesity, with fat deposition around the sort of the torso, and all these horrible side effects. And you can come off the steroids, and these steroids were life-saving. They put up with all of these side effects because this saved their life. They weren't going into hospital being unable to breathe several times a year. Mm-hmm. And they got put on their interleukins, the anti-interleukin 5s, for instance, or the others, and they got a whole lot better without the steroids. because these are very precise. They're just knocking out steroids are dirty. They just knock out every part of the immune system. You don't want that. You want nice, clean, precise, targeted precision, and that's where the term comes from, precision medicine, to try and get much closer.
Right.
And the same is true in certain people in chronic rhinosinusitis. The question is, are those the right biomarkers? So we have rules, we have guidelines. So you need to have a high eosinophil count. You need to have had previous surgery. We need to know that the polyps have come back at least once. We've got sort of guidelines that we're working towards, but we don't have the real biomarker, the real thing that you do a blood test and that you know they have that blood test, they have that result, they take these drugs, they will get better. We don't have that yet. It is working its way towards it, but that is the challenge at the moment.
Wait, hang on. Well, I have one more question, Aidan, before we get to your questions. Does CRS ever clear up spontaneously?
I mean, I obviously don't see that many people when they get better spontaneously, but they certainly do. I mean, I suspect not the bad ones. Certainly Allergy used to, and doesn't seem to that much anymore. But you used to sort of grow out of it around 60 or 70, but that seems to have changed in the last 10, 15 years. But some people do, yeah. Okay. Generally the milder ones, and it's slightly related to the distribution. So if they have a central compartment disease, so mainly in the nose around the sort of entrance to the sinuses, and you clear that out, then usually people get on okay with that. Okay. It's when it's more diffuse that it's a problem.
Okay, thank you. So Aidan, why don't you ask one question, and then I'm going to go and look into, while you're asking, I'm going to look into the Q&A and just see what we can.
Sure.
Yeah, go ahead.
I had a question specific to anti-inflammatory, but we can speak to you about it after. So we've got one here from Fallout Man. My most troublesome symptom of chronic sinusitis is a weak sense of smell and taste. Is it possible to restore and maintain it? It might also be a link to Chrissy as well. So maybe you want to take it away, Simon?
Yeah, I mean, yes. So oral steroids usually, and this is so I say a joke that I can talk about polyps forever, which you've seen me do for half an hour already without even breaking a sweat. But one of the things I like about this disease in terms of smell loss is I know what to do with this. I know that for almost everybody with nasal polyposis, a short course of oral steroids will bring the sense of smell back almost completely, and back to normal in a way that, for instance, post-viral olfactory loss or traumatic brain injury olfactory loss is not. Well, it's much harder to get that kind of miracle wave a wand. And we were talking about biologics. The papers that have been published on research and biologics and CRS also show that they have an effect on the sense of smell. So, and that's very positive. If these things seem to be as safe as they are, and they really are, do seem to be. I mean, we've only got short-term data, really. The longest we've got is so omalizumab was released in 2006. So that's quite long, and they seem to be quite safe for the data that we have. Then that would be great if you can just give these injections once a month or once every 2 weeks and bring people's sense of smell back almost completely. That would be, it's not a cure, but it's getting there.
But I'm guessing that people have to keep taking these oral steroids when it comes back to keep the sense of smell.
The oral, So the oral steroids, yes. If you're severe enough, then yes, you can. Depends on the severity of the disease and what else you're taking. But you can. The steroids do work at least temporarily. And I have some patients who just, they take their steroids in Christmas so they can enjoy their turkey, and they take it when they go on holiday. And you can probably take them roughly once every 6 months or so without too much problem. And that's what we do. We just, get in between and sort of time it so that when your sense of smell and taste is as important as it can be, that's when you switch it on. But as I said, the biologics, if they are as safe as they are, they're going to be as they seem to be, rather than that's going to be revolutionary. To just take one injection a month instead of putting things into your nose every day and washing it out and all those things, that will be fantastic for people.
Of course, biologics are very expensive, are they not? So that's
eye-watering
consideration. I mean, obviously here in the UK, if you qualify, you can get it on the NHS, but they're not offered on the NHS. No.
They're offered on the NHS at the moment for some skin conditions and for asthma.
Right.
And if your asthma is bad enough that you're requiring oral steroids, then you can qualify for them. But at the moment, we do not have. They're licensed well, some of them are licensed for use for nasal problems, but they are not available on the NHS.
Right.
So that is that, and the way that drugs come onto availability in the NHS is through a process with a body called NICE, the National Institute for Clinical Excellence,
right.
which essentially looks down and looks what are we paying for what kind of benefit, and that we are going through with some of the biologics at the moment, but that has not been finalized and may not be. They are very expensive, and some people can afford them, but most people can't.
Right. Well, who knows? That might change as drugs develop. I mean, we know that they do tend to get cheaper, so that might be.
Yeah, if you look at when we were discussing this a couple of years ago, we looked up the initial cost of corticosteroids, so cortisol, in the early 40s, when it was isolated from the adrenal glands of cows, so it was exorbitantly expensive. And the cost per dose for cortisol is roughly what the cost per dose for one of these biologics is at the moment. Right. In terms of, but 9 years later, it was down to almost a fifth of that. So it's really, okay, I mean, that's to do with the intellectual property. Things weren't quite as developed back then. They found better ways of manufacturing them, et cetera, but I'm not expecting that kind of precipitous decline in the price, but it probably will come down, yes.
Right.
But compared to cortisol now, which is pennies, maybe not that good.
Right. So we've got some other questions coming in. As Simon said, we can't really comment on individual cases. I see quite a few questions coming from people who are talking about their own particular situation. So I will ask one question here. Someone says that she is allergic to dust mites. Nasal steroids and asthma inhalers control my symptoms, but is this the only control? Would biologics or immunotherapy ever play a part in control of this kind of condition? What do you say to that?
Okay, so this comes back to the point that we made at the beginning. It's very important to isolate. We're dealing with two separate diseases. There's lots of overlap, but they're two separate diseases. Allergic rhinitis, hay fever, which is allergy to house dust mites, and chronic rhinosinusitis with or without nasal polyposis. And as I said before, there's sort of lots of overlap in terms of symptomatology and causation. House dust mite allergy can be treated with immunotherapy. That's the take-home message, because it's allergy, immunotherapy, either sublingual or subcutaneous, delivered in a safe way by a trained allergist, definitely.
Right.
It's usually reserved for people with severe disease. In other words, if it is controlled with a simple nose spray and maybe an antihistamine once in a while, do you really want to take the risk of taking immunotherapy? Because when it was first developed, they're probably using sort of thousands of times what we would use now as the dose, but people died in this country. And so for a very long time, immunotherapy was just off the cards. Nobody would even consider it. We now have much safer ways of giving it, including, as I said, under the tongue. But the worst form of allergy is something called anaphylaxis, which is sort of systemic collapse from allergy. There's massive release of inflammatory mediators, loss of blood pressure, the heart can't pump enough fluid around the body, and it can be fatal. and these sort of fatal allergic reactions can happen to almost anything, sadly. But it is something that you need to consider if you're going to consider immunotherapy.
Right.
I don't want to put people off. You know, given in the right setting with a trained staff, it's nowhere near the risk that it was. But you have to always look, and it's something that I say over and over again, Chrissy, I'm sure you're sick of it every single time, is we always have to look at what's the risk and what's the benefit of any treatment or intervention we're talking about. And immunotherapy, you have to be bad. You have to really be somebody who's going to benefit a lot before it's worth taking that risk.
Right.
But there are.
Yeah, excuse me, I didn't mean to interrupt. But and that is also, you know, the reason why you need a good doctor who will listen to your whole story. And it takes more than, you know, the 8 minutes that you might get with a GP. You know, if with a complex problem like this, you really do need a different kind of care.
Yeah, and there are allergists, specialists who deliver this kind of thing. We have an immunotherapy program at the Royal National Throat, Nose and Ear Hospital, which is you know, massively oversubscribed, as you might imagine. But there are specialists, and talking to your GP about a referral to that would be a way forward in this country.
I'd like to just ask a question here. Someone has asked, what about maintaining a normal sense of smell for patients without nasal polyposis? Mine is very weak. So I think this is somebody who must have chronic rhinosinusitis, but who feels they are losing their sense of smell. And this comes up occasionally, you know, what is the role of smell training for someone who might be in this situation? What are your thoughts on that, Simon?
I was going to defer this to you, actually, but I think from what my current understanding of the way smell training works, if I'm right that you're recruiting, if we are right that we're recruiting new neurons, we're keeping nerve cells that do the smelling around for longer because we're stimulating them more, we're probably increasing the connections within the brain that are to do with smell. All of those things mean to me, if you're losing your sense of smell, the best, if not the only way of keeping it around, is to smell train with it. And this just, you know, that's true for almost everything. The more you use it or lose it. It's true for brain training. It's true for muscles. It's probably true for smell training as well. So, and we know this from training perfumers. People who go into perfumery that's been looked at, they aren't any better at smelling than any random sample of the general public. They learn to be better. They learn to be these amazing noses because they train and practice. And that's what we are trying to do with olfactory training.
For anyone who is interested in smell training, and especially if you've got, you know, chronic rhinosinusitis, you might want to join the Tuesday evening Zoom in August. I think it's August 18th, when Jonas Olofsson from the University of Stockholm will be here talking about what happens to the brain when we smell train. And I think that's going to be a really interesting evening. So I hope you put that on your calendar. And of course, as all of these sessions, if I remember to save the recording, I forgot last time, you will see the whole thing again on YouTube if you are not able to join us on the night. So yes, so that's that. Okay, now let's get back to some more questions. Someone says, I have no other autoimmune symptoms, so it would seem unlikely that the interleukin treatment would be effective for me. Surgery now seems less of an option than I thought. If the polyps just grow back, and you've made steroids sound quite horrific. So what's left?
So the polyps themselves are an autoimmune disease. I think we are recognizing that there's an immune dysregulation that's causing this disease, and there are no other, that doesn't mean anything whether or not you have other autoimmune symptoms or signs. The disease itself in the nose is that. Surgery is definitely has a role. It works, people feel better, and if it's performed properly, you get good benefit for 5 years or longer, depending on the severity of the disease and everything else. And what we currently offer is a multimodal approach. So surgery if required, steroids if in the nose always, and then systemic steroids as necessary. And I didn't mean to make steroids sound horrendous. They can be, but that's chronic long-term steroids taken every day by mouth. That's completely different, and this is on me for not making that clear from the start. That is completely different from the steroids we use in the nose. Most steroids that we use in the nose are exceptionally safe. They are not absorbed into the, well, 0.1% absorbed into the body. So they're really just, the rest of the body does not see what lands in the nose. It just works in the nose on where it lands. Everything else is fine. And if you have any skepticism, there are published experiments looking at the lining of the nose in people with disease that needs steroids, people without the disease that needs steroids, and people with the disease that needs steroids that have taken the intranasal steroids. And the people who don't have disease and the people who have intranasally treated disease, they have normal looking lining. The ones who need the steroids but don't get them, they're the ones who look very abnormal. So
Right.
unlike in the skin, where topical steroids can cause thinning and all sorts of other things, in the nose, they make your nose more healthy. So,
Interesting.
So systemic steroids, if you need them, you need them. They're not great, and we know that. In the nose, go wild. You can take them for as long as you need to. They're not going to be a problem. Chrissy, I'm a bit embarrassed that we haven't mentioned washing out the nose yet.
I know, and
your favorite.
We've had a question about that, so I think this would be a good time to mention how good that is for all kinds of things. So you could carry off you go.
Well, no, you're the cheerleader on this one. No, I mean we know that, again, the evidence that we have looking at people who have nasal problems, if you wash your nose out with salt water, it doesn't. Most people, when I suggest it, go, oh, and they remember getting in the pool and the water going up their nose and stinging and burning and eyes watering and everything else like that. That is a function of the that's a function of the tonicity of the amount of stuff dissolved in it. So pure water obviously burns because the cells don't like that. Saline, which is the same as the fluid in our cells, doesn't burn like that. It's quite comfortable and makes your nose feel really nice afterwards. Yeah, and so I think it's vital, especially. So we haven't talked about the sort of theories of causation of polyps, but certainly there's some evidence that air pollution has something to do with it, that has a role. And if we're all living in these polluted cities with high nitric oxide, with particulates, all those kind of things, washing them out twice a day for most people, even if they don't have that bad a nose, probably not a bad idea.
Yeah.
Yeah, as you know, I say everybody should be washing their nose.
Maybe treat it like mouthwash, but do it as often.
Yeah, exactly. Or brushing your teeth.
Yeah.
Although I don't think you get mint versions, do you?
Oh no.
No, you wouldn't want that.
That'd be awful.
That's exactly. I mean, that's what you're doing when you brush your teeth, right? It's a physical cleaning of the stuff that doesn't get cleaned by the normal processes in the nose. That's exactly in the mouth. Well, that's exactly what you're doing in the nose. Physically, just moving things along.
And I think a lot of people, as you said, are squeamish about that, and they have difficulty getting over it the first couple of times. But once you've done it, and you know how good you feel afterward, it's just, it's magic. Everyone should be doing it.
First taste is free.
Yeah. Exactly, and just you will get over it.
Yeah.
So I'm a big fan, and also I'm not so much of a fan of neti pots. I find them not as good as the bottle, which you can squeeze to really propel the water where it needs to go. Whereas a neti pot relies on gravity to take the water where it needs to go, and I'm not so sure that's a good.
Different things work for different people, and some people find the squeezy bottle too overwhelming. But even a rinse with something like the saline sprays, Stereomar is an example of that. Others are available. They're better than nothing. They clean out the front of the nose, and again, they get you used to having your nose cleaned out and sprinkly fresh.
Yep. Absolutely. You may be interested to know that we are at this time preparing some e-learning modules for the British Rhinological Society. They have been
Very
kind enough to
interested.
support that for us, so we're making those. And Simon and I and Professor Claire Hopkins have created some videos that will be part of this e-learning program. And all of that will be found within the AbScent website. So I'm hoping, fingers crossed, that in about 2 weeks, it will be up there so you can take a look. And one of the things that you can see is Simon rinsing out his nose with a Neilmed rinse bottle. Other bottles are available. So
Very glamorous.
if you aren't sure what it looks like or how it's supposed to work, tune in and take a look at that. We also have some videos, or we will have some videos about the correct use of nasal sprays, the correct use of steroid nasal drops. There's a new method, or I don't know, how old is the Kaiteki maneuver?
It must be going on 10 years now.
10 years, okay. Well, I think most people tend to
guess.
pop in their nose by putting their head either off the back of the mattress or by putting their head on the floor. But there's a new method that doesn't involve wrenching your neck and is a little bit easier. And so we've got a video of that as well. So all that is coming, and do follow the feed on Facebook, or if you follow me on Twitter, you'll see ample news about that. You can also sign up on the AbScent website for our newsletter, where you will
That Kaiteki position has also been shown to maximize delivery to the olfactory cleft as opposed to the other positions, which are good for sinus disease, but not so much to the smelly bits.
Right. Good. Okay. Have we got any more questions, or have we?
Permanent loss of smell from chronic sinusitis? Is that?
Yeah. So there are a couple of things. Unfortunately, it's so the problem is, number one, the sort of the historical long-standing chronic rhinosinusitis people can have had for 20 or 30 years. 30 years ago, we didn't understand what we understand now about this disease and how it's managed. We didn't have access to nasal steroid sprays. So people may have had a lot more aggressive surgery. Some surgery might have been performed without a realization of the anatomy that really only developed more recently. So surgery itself can cause smell loss. But equally untreated inflammation within the nose, destruction of the normal anatomy from aggressive polyp disease, and that inflammatory process that I was talking about earlier can also all do that. So that's why I can remember when I was first a junior doctor talking to Professor Valerie Lund about this, and she said, usually if people's smell doesn't come back within 10 years, then it's not going to come back. Mm-hmm. And although I never give up hope and have managed to help people get their sense of smell back, that's always stuck with me, that and this is why I'm perhaps slightly more aggressive in my management of this disease with medicines than others of my colleagues, because I think that you've got to use it to preserve it. And so that's why we have these steroid smell holidays and things like that, because I need to try and keep it around for as long as possible.
I know one member of the Facebook group who has all these kind of problems, and then suddenly, for a reason that she didn't understand, she got her sense of smell back, and she had it for about 5 weeks, and then the clouds drew in, and then suddenly the sense of smell was gone. So that tells me that somewhere up there, the nerve is intact, but there is some sort of blockage that is preventing her from getting the volatile molecules. You think that would be correct?
Yeah, and there's quite a common story of people getting a cold or infection or changing environment, and suddenly the smell going for a couple of days and coming back. Whether that is because you're mounting a different type of immune response and that modulates this T2 inflammation that we see, or who knows. But yes, I mean, yeah, so the sudden onset and offset is the key, as you say. That means that there's an intact smell there somewhere. We just need to get to it.
Right. So I'm guessing with something like smell training, with polyps, obviously you've got an obstruction in your nose. Is smell training quite good for people to make use of their nose? Because if you're not breathing through it, you perhaps maybe don't have this training from smelling different things. So
from my point of view, the problem is that it's access to the olfactory cleft or the olfactory cleft itself that's the problem. So if we think that smell training is working by encouraging the population of cells to proliferate within the olfactory cleft, then it doesn't really matter in polyp disease because it's already there. They're probably not going to spread outside that to where they can access the olfactants any easier. So I think it's worth it for people who have a small amount of smell recovery to really work on boosting it up. But I don't normally recommend smell training to people with polyp disease because it's, as you say, obstructive and slightly inflammatory.
Right.
And it can usually be, and that's often a diagnostic test for me, is we'll use some strong steroids and see whether the sense of smell comes back. That tells you a lot.
And it's, I would say, also important to point out, I know people who were just in that place and the doctor wanted to use a short course of steroids as a diagnostic tool, but the patient was too worried about the side effects of steroids and wouldn't take them. And, you know, again, it's not a long-term thing. It's just an easy way to see whether or not it's the blockage that's the problem, and that and whether or not the olfactory nerve is intact, you know, up there where it's not normally able to come into contact with the volatile molecules.
Yeah, several weeks for most people, if you're otherwise healthy, several weeks of a moderate course of oral steroids is absolutely fine and will make you feel great.
Yeah.
But you know, it makes you hungry, makes you people often talk about being bulletproof, gives you a lot of energy, difficulty going to sleep. Yeah. But generally, if you're not having problems with blood sugar management, totally safe to take it. And as I said, probably every 6 months or so, absolutely fine.
Right.
Very interesting.
Okay, well, we might have time for one more quick question. Aidan, do you have anything for us that we can answer in about a minute? Nope. No, I think actually we may have covered those. Okay, well, what I'll do now is just tell you about what's happening next week. Now, normally these Zoom sessions happen every 2 weeks. If you're watching today, it's because polyps or chronic rhinosinusitis are your problem. But next week, I will be having Professor Claire Hopkins again. She will be talking about the latest research. She's been involved in research on COVID-19 patients herself. That research has not yet been published, but she's going to talk a little bit about what they've seen so far. So if that interests you, you are of course welcome. And then the following week is the 4th of August. And on the 4th of August, I will have with me Professor Thomas Hummel and Valentina Parma from Temple University, and they will be discussing with me what's been going on with the Global Consortium for Chemosensory Research. So that, again, that's a COVID-19 subject. So I think that will also
lineup.
Be very, very interesting lineup, yes. And of course, Jonas Olofsson later on in August. So do tune into any of those. And I think otherwise, I would just like to say thank you to my audience for coming today to join us in this. We are here to help you. So if you've got suggestions, if you want to talk about polyps again, by all means, suggest that.
I'm here.
You know we'll be back. You know we'll be back to talk about polyps. And abscent.org is the website. You're welcome in the Facebook group. So that's really my message for tonight. So thank you to Aidan Kirkwood, who has been manning the, he's wearing his cordless headphones tonight. You can notice that he's got no cord on them. Simon's wearing his ear pods. I'm just listening to the audio coming from my computer. Anyway, thank you very much, everyone. Good night, and we'll see you another time.
See you.
Bye.
Bye-bye.